My name's Dominic Power. I'm a consultant hand and peripheral nerve surgeon based in Birmingham in the UK, and I'm one of the editors for OrthOracle Hand, Wrist and Peripheral Nerve. This video is for patients, and it's about the use of processed nerve allograft in reconstruction of peripheral nerves. Nerves are the electrical cables in the body, and they send signals from the brain and the spinal cord out to the arms and the legs. Incoming signals from the skin tell us about our environment and what we're touching. They are there to protect us if we touch something hot, and the body then sends a signal back out from the spinal cord to allow you to remove your hand and prevent injury. Now, sometimes these nerves can be damaged, and when they're damaged there can be a gap, and that gap must be rebuilt. The traditional method of rebuilding a nerve gap is to harvest nerves from somewhere else in the body that are perhaps less important, and usually the nerves can be taken from either in the forearm or, if a longer piece of nerve is required, from the legs. But of course this comes at a cost to a patient. The patient then ends up with an additional area of numbness in the skin somewhere else, and sometimes when the nerve is harvested, the remaining end of the live nerve can overgrow and form a lump called a neuroma, which can be painful. Processed nerve allograft is nerve taken from human bodies at the time of organ donation. It's prepared in such a way that it doesn't contain any of the cells of the original donor patient. It's treated in a way and then preserved and frozen, and it can be used to bridge gaps in nerves after injury. It's pretty successful at doing this, and in particular there's very good evidence to support its use in repairing nerves that control feeling. At the moment there's less evidence for its use in nerves that control both feeling and movement, but the data around that is continuing to improve, and publications are appearing on a regular basis supporting its ongoing use. The benefits for patients are that the surgeon can actually undertake the operation perhaps on the arm or the hand under a local anaesthetic or a regional anaesthetic block without the need to put the patient to sleep to harvest nerve from elsewhere in the body. The patient doesn't have the risk of pain at another site, and the patient doesn't have the risk of loss of sensation somewhere else in the body. The surgeon uses the nerve, which is effectively a scaffold, to bridge the gap between the damaged nerve ends, and then the nerve cells or axons grow across that, using this scaffold as a bridge back over the missing piece of nerve into the distal nerve stump, and then they continue to grow to the skin for feeling and to the muscles for movement. Your surgeon can talk to you about the options for using processed nerve allograft in nerve reconstruction, but there are some specific things you need to know. The allograft is harvested from other humans at the time of organ donation. It's prepared to remove cell material, so you don't need any drugs for immunosuppression, and it's screened to eliminate the risk of infection transmission. It's rapidly becoming the gold standard for treatment of painful, feeling nerve conditions in the upper limb, particularly for the reconstruction of neuromas. But the evidence to support its use in all nerve repairs is not quite there yet. And as a result, in the UK, the National Institute for Health and Care Excellence have recommended that patients should participate in long-term data collection so that we can understand how this performs in all nerve reconstructions. Your surgeon will talk to you about it and explain that process, but it will involve you completing some forms explaining how the nerve injury has affected you, and the surgeon and their team of rehabilitation specialists will be able to monitor your recovery and compare that with data sets from around the world in something called the Ranger database. Thank you.